can expect the same. So we can also expect calcification along with, as you already seen, fat density, hemorrhage, necrosis, etc. So if you see all these things, we can suspect a hepatic adenoma. Next we come to focal nodular hyperplasia, which is asymptomatic or incidental tumor. The etiology is unknown and is characterized by a typical central stellate fibrovascular scar. So you should remember this key point. It's a typical, what is typical of focal nodular hyperplasia is a central stellate fibrovascular scar, which is seen in 50% of cases. So it is also an hypervascular lesion, but we'll see how this scar enhancement in contrast will help in differentiating it from other hypervascular lesions. So it contains normal liver elements, unlike the hepatic adenoma, which does not have Kupffer cells and bile ducts. Here we will see Kupffer cells as well as non-communicating bile ducts. An ultrasound, it's a well-defined isoechoic mass, homogeneous echo texture, and we come to the typical feature, which is a central hypoechogenic scar. So central hypoechogenic scar in an isoechoic, well-defined lesion, homogeneous lesion. Should suspect this lesion. So calcification is seen in 1.4% of the cases. So in Doppler, we get a stellate flow pattern, and contrast enhanced ultrasound shows the central A area with centrifugal filling. See, you should remember that the fibrovascular scar in this focal nodular hyperplasia is vascular. It's not just fibrous, it's also vascular. Therefore, there is a Doppler flow pattern and also a centrifugal filling in contrast enhanced ultrasound. So non-enhanced CT scan will show a well-defined lesion with mass effect displacing the hepatic vessels. An attenuation is same as that of the liver parenchyma, and if fat is more, the lesion can show a low density. A central scar is common, as we saw 50% cases. So what happens in the arterial phase is the lesion enhances markedly, whereas the scar does not enhance. So we go to the next phase. You can see it in the upper right. The lesion is enhanced, the central area of hypodensity, which is scar, which is not enhanced. And then we come to the portal venous phase in the left bottom, where you have a isodense with the liver, scar is low, and that's delayed imaging. We get, again, there's a washout in the main part, but the scar shows enhancement. So the left bottom is the delayed phase, not the portal venous phase, but the delayed phase, because it shows the scar enhancement along with the washout in other parts of the lesion. So that the right bottom is the pathology specimen showing the scar. So the typical pattern is like a hypervascular lesion, rapid uptake and washout in the normal part of the tumor, whereas in the scar part of the tumor, we get a delayed uptake. So in the delayed phase, we'll have an enhancement. So that is diagnostic of a focal nodular hyperplasia. I'll come to hepatocellular carcinomas, the most common primary malignancy of the liver, next to metastasis, which is the most common malignancy of the liver, but the secondaries. This is the most common primary malignancy of the liver, so you have to differentiate between the two. So if the question is most common malignancy, it's metastasis. If the question is most common primary malignancy, it's hepatocellular carcinoma. So the incidence is rising, attributed to rise in hepatitis B and C infections. Hepatocellular carcinomas can vary in size from small tumors to large tumors, and small tumors in ultrasound are hypoechoic with posterior acoustic enhancement. More than 3 centimeters show mosaic or mixed pattern, which means it will not be homogeneous, and it will have a different echogenicities or mixed echogenicity noted. Now we come to CT scan, we see 3 patterns. One is a solitary, multicentric, and diffuse. Solitary is, as you know, single, multicentric, multiple focal lesions in the liver which are malignant, on primary also, and diffuse. Diffuse infiltration of the liver by the tumor. Next we come to large hyperdense masses. This may show central low attenuation due to necrosis. So this typical hepatocellular carcinoma can show areas of degenerative change, calcification, necrosis, hemorrhage, etc. So focal calcification seen in 7.5% cases. So we see this shows the typical pattern of a hypervascular lesion, which is nothing but fast uptake in the arterial phase and rapid washout in the venous phase. So it's a hypervascular lesion, and we cannot use this to differentiate it, but we can, since it's the most common primary malignancy, we can always keep it in our differential. Heterogeneous enhancement can be noted because of central necrosis, and on delayed images there is it is isodense to the liver. So tumor may invade the portal vein, IVC, and these can be studied using the contrast scan, because on contrast study, if the soft tissue lesion in the liver or in the portal vein and IVC enhances like that of the liver, then it is a case of angioinvasion, whereas in the case of absence of enhancement, it is thrombus. So the arterial phase, you can also demonstrate arterial branches and arterial portal shunts. So the abnormal vascularities which develop in the lesion. Portal venous phase, you can see low attenuation focus in right portal vein. Okay, so this is the low attenuation focus, the right portal vein. So that shows could be, so it is obstructing the flow of contrast into the liver.